All right, we're going to go ahead and get started. Hi, everybody. My name is Tess, and I'm so happy to welcome you to the 7th Annual Cannabis in Practice webinar series hosted by the Washtenaw County Health Department and Livingston County Health Department in partnership with the Washtenaw County Medical Society. This webinar series is aimed at addressing questions our local and regional healthcare providers have about cannabis use and their patients. Our speakers come from a wide range of backgrounds and are experts in their respective fields. Funding for this series comes from the Michigan Department of Licensing and Regulatory Affairs Cannabis Regulatory Agency. To review some housekeeping notes, all participants will be muted throughout the session. Please use the Q&A box to submit questions, which will be answered at the end of the presentation. If you require a live transcription, select the Show Captions function. If you don't see it, resize your window to be wider. This live webinar has been approved for 1 credit hour of social work continuing education, McBAP credit, CHES credit, Mishwa credit, and CME credit. If you are requesting any of these continuing education credits, please be sure to stay until the end of the webinar to fill out our post-webinar evaluation survey. This webinar is being recorded. The webinar recording and presentation slides will be available on our website, washtenaw.org/marijuana, in the coming weeks. Before we get started, we ask again that all questions for our speaker be asked through the Q&A function, which can be found at the bottom of your screen. We'll have time at the end of the webinar for the speaker to answer questions. I am pleased to introduce today's speaker, Dr. Leslie Lundahl. Dr. Lundahl received her PhD in clinical psychology from the University of Wisconsin and then completed her postdoctoral training in behavioral pharmacology at Harvard Medical School. Currently, she is a professor in the Substance Addiction Research Division, which within Department of Psychiatry and Behavioral Neurosciences at Wayne State University School of Medicine. Her research, which is funded by the National Institute on Drug Abuse, focuses on understanding and treating addictive behaviors. She has been involved in many studies of behavioral and brain processes thought to underlie substance use disorders. Currently, she is investigating new approaches for treating cannabis use disorder, as well as investigating potential risks and benefits of cannabinoids used as therapeutics. In her clinical practice, she specializes in using behavioral therapies to treat adolescents and adults with substance use and comorbid psychiatric disorders. Dr. Lundahl is committed to teaching and training graduate students and medical students, as well as community treatment providers in the assessment and treatment of substance use disorders. And now I am happy to turn it over to Dr. Lundahl for her presentation.
Hi, thanks, Tess. That was a great intro. Hi, everybody. Thanks for inviting me to speak with you today. I am going to share my slides here. Let's see. There we go. Does everybody see that first slide? I hope. Yes. Great. Okay, let's get started. So I'm going to be talking today about adolescent cannabis use. I have no financial disclosures to make, sadly. What I'm hoping to have everyone get from this talk today is understanding some of the current trends in adolescent cannabis use, especially some of the newer formulations and routes of administration that have a lot of us concerned. We'll talk about some of the effects of cannabis use and what some of the potential risks are specific to adolescents. And then we'll discuss screening and intervention for adolescent cannabis users. So the first thing I want to talk about is cannabis use. So these are data from the most recent Monitoring the Future study. This is a survey study that's conducted annually at the University of Michigan. And it collects data not only on drug use, substance use, but also attitudes about how available it is and how risky it's perceived to be. So these are combined data going back from its first administration in 1975. It was only 12th graders here in the red. And then in, I think, 1990, they added 10th graders and 8th graders. So what I want you to focus on here is that so in the late 70s, 80s, this was sort of the heyday of cannabis use amongst 12th graders. And it really steadily came down until around 1990 when there was a resurgence here. And so it has cropped up and stayed pretty level since then. What I think is interesting is that 2012 is when we first had states that were legalizing, and there was not a huge jump in adolescent use here in any of these age groups. Partly that's due to the fact that it would be illegal for teenagers anyway, if it was, even if it is legal in the state, and teenagers have always used cannabis despite it being illegal. So I guess legality doesn't really seem to have affected their use that much. This drop here follows the pandemic restriction. And so as you might imagine, kids were not leaving home. They couldn't go meet their dealers or meet their friends and get any cannabis. And there was a lot of supervision because parents were typically home. What's interesting though is that it's creeping up a little bit, but we have not returned yet to pre-pandemic levels, which is pretty interesting. So the most recent data that I just looked at the other day from the 2025 publication that's about to come out, these are for data in 2024, about 26%, so about a quarter of 12th graders report using in the last year, 16% of 10th graders, and 7% of 8th graders. And so again, this is just in the past year use, which we would consider sort of current use. If we were looking at ever used, these numbers would be way up here around 50%. Okay, so this is vaping. I'm a little bit more concerned about vaping than smoking. And again, so this is when the first vapes and oil pens for cannabis first came onto the market. And there was a huge jump in use over those first few years, especially for the 12th and 10th graders. These are the use rates compared to what I just showed you. So 20% of 12th graders report vaping in the last year. Remember, 26% of them reported using. What these data show, especially scary for the 8th graders, the little ones, is that most of the kids who are smoking marijuana are also vaping marijuana. And we'll talk more about the risks of vaping and why I think that's a big deal in a minute. So going along with these use data are some of the trends in perceived availability. So what's interesting here is that around 1976, when we were looking at these data, it's always seemed available to 12th graders. If they want to get a hold of it, about almost half of them say, if I wanted to get some, I know where to get it. It wouldn't be hard to get. Again, this drop off during COVID, but seems to be climbing back up. The other thing I want you to really notice is this relationship between perceived risk in blue and rates of use in green. And so as you might imagine, there's an inverse relationship that as people think it's risky, the use comes down. As the risk starts to come down and people think it's really safe, we're going to see the rates of use starting to go up. And so those are a pretty consistent relationship that we see. So why are we especially worried about cannabis use during adolescence? Well, we know that adolescence is a time when most people start to experiment with drugs. We know that these changes in recreational use laws have changed not so much use, but certainly changed this perception of accessibility and availability, but also decreased risk of harm. And the other thing that I think is really, really different, we have all these new products that are sort of exploding onto the market. We have new routes of administration. And probably for those of you who work with adolescents know, adolescents are among the first to try anything new. So they are the ones that are really trying these new products faster than just about any other age group. We also know that adolescence is a time of extreme vulnerability to brain insult. The neural substrates that underlie cognition are most active. There's a lot of changes, a lot of development that's occurring both in structure and function. And because cannabis has such diffuse and widespread effects in the frontal cortex and the limbic system, there's really a lot of opportunity for disruption in neurodevelopment, and that can translate into interference with social and academic function, psychological function, to a much greater extent than we would see in later developmental periods. So let's do a really quick cannabis review. I understand you've had a lot of talks about this already recently, so I'll keep this very brief. The cannabis plant has hundreds of cannabinoids. The two most common that you're going to hear about are delta-9 THC or tetrahydrocannabinol, and then cannabidiol or CBD. THC is thought to be the primary psychoactive compound in the plant. CBD is considered not psychoactive, but there are some data in studies showing that it may have some anti-inflammatory, some anxiolytic, and almost sedating effects. So I'm not sure we can keep considering it not psychoactive, but we'll follow the data on that. When we talk about potency of cannabis products, which you'll hear me refer to throughout this talk, generally that's defined by the content of delta-9 THC per unit or volume. So generally that's expressed as a percentage. So I'll say percent THC, and that's it for a product that's inhaled, or in milligrams of THC, and that's generally with products that are ingested, like eaten or edibles or drinks. There are hundreds of varieties and strains. If you go into a dispensary, you will be inundated by a huge number of cultivated strains, and certainly these are all available on the regulated market and also available on the non-regulated or the street market. So one of the things that I think is so interesting about THC, there are a huge profile of effects that come with THC or cannabis. The way THC works is that it binds to cannabinoid or CB1 receptors. The highest concentration in the brain are found on the nucleus accumbens, the hippocampus, the amygdala, and the cerebellum. And this is why we see effects on memory and coordination, appetite, sleep, mood, motivation, driving, all of these things is because if you look at these little yellow spots, these are all receptor sites, CB1 receptor sites in the brain. So they are all widespread through the brain. The prefrontal cortex, things like around judgment, planning, inhibition, memory, all of these things are affected. We also know that CB1 receptor binding seems to be stronger in teens than it is in adults, meaning that they can be more affected by the effects. That made sense. So you know what I mean? So we know that when you're high, you can be well, let me get to that later. When you get high, it's a very pleasant, sort of relaxed feeling. THC is considered a hallucinogen, it's classified as a hallucinogen, but the hallucinogenic effects are actually quite mild, nothing like a true hallucinogen like LSD or psilocybin or peyote. There's a sort of relaxed sense of well-being, a little bit of euphoria. The hallucinogenic effect is much more of a mild perceptual distortion. So like things are funnier, things smell better, sounds are different, music's different. People get the munchies. One of the things that I think we need to really pay attention to is that there are a lot of studies recently that have shown pretty aversive effects of THC on driving. And we have to worry about that. We don't currently have a field sobriety test for THC. And according to some talks I was at recently at a conference, we are nowhere near having anything like that. So that's something to sort of be concerned about, especially with teens. As the high wears off, a lot of people feel very sleepy. They can feel sort of a downer kind of effect. And probably the most consistent effect to THC is a rapid increase in heart rate from 20 to 100% in beats per minute. So that is something that pretty much everybody experiences, and there is no tolerance that develops to that. So having an underlying cardiovascular issue can make cannabis a dangerous drug for you. We also know that when you're high, you're kind of dumb. There are very clear impairments in attention and memory and learning. And if you've been with anyone who's been really high and tried to have a conversation with them or tried to get them to remember something or pay attention to something, you have experienced that it's pretty difficult. We know there's some evidence of impairment in concentration and judgment and decision-making, motivation and motor performance, but the really strongest impairment is remembering complex tasks or bringing in new information, keeping track of conversations. We know that these effects are dose-related, right? The higher the dose, the higher the impairment. We also know that some people have pretty adverse reactions. People can feel anxious or dysphoric. They can get a little paranoid, maybe a little panicky. At very high doses, we'll see acute psychosis. This would be characterized by a paranoid ideation, delusions, actual hallucinations. And these are very high doses, obviously. The paranoid effect seems to intensify with age, which is sort of interesting. And I'm not sure if that's because older people pay more attention somatically. They feel that heart rate increase and that makes them sort of nervous, or that they know there's more at risk if they get caught being high. But there's some reason that the paranoia seems to be a little bit stronger with age. All right, so one of the things I also want to talk about is the changes in cannabis potency and routes of administration and how these translate into higher risks of use. These data are from the DEA, and these are based on samples that were seized by the DEA starting in 1995 up until the mid-2000s. The ones after that are kind of are averages that are of products that are available in dispensaries. So back in the 1980s, when some of us were in high school, if we were to buy marijuana on the street, it would have been around 3% THC. So 3%, 3 to maybe 4% THC. Around 1995, that jumped up to 5%. We are now seeing strains around 25 to 30% THC in the dispensary. So we've gone from 2 to 4% THC to 30% THC. One thing to keep in mind is that all the studies, or most of the studies that we have about the effects of cannabis on the body and the brain, that I'm going to talk about in a minute, are based on people using 2 to 4% THC. So we don't even really know what some of the deleterious effects and long-term effects of these high potency or higher potency products really might be, because we just don't have the data yet. These products are too new. The other thing that I really am concerned about is that, so this is the rise in THC in plant. This red line, this is concentrate. So I'm sure you've all heard about high potency concentrates, or vape pen or oil pen cartridges. These are high potency concentrates that are upwards of 90% THC. There are some dispensaries that are advertising 99%. I don't know if that's accurate, but if you think about that, this is a completely different product. These contain 3 times the level of THC compared to the very highest level of flower that you can purchase. So these are really incredible products in terms of their THC potency. So what's responsible for this is new cultivation techniques. As we know, I just said cannabis flower can be up to 30% in dispensaries. In Colorado, the average concentrate product is 62%. In Detroit, you can certainly get 62 and higher. These dispensaries are advertising cartridges, as I said, that are more than 90% THC. And so that's very concerning. Another shift is in how and why teens are using cannabis. So we used to see a lot of use being reported because kids were bored, or they wanted to try it, they wanted to feel high, they wanted to experiment. Now we have a lot of kids saying, I'm managing stress. School is really stressful. My sports teams are really stressful. Applying to college is stressful. They're self-medicating anxiety. They're dealing with painful emotions. So there's been this real shift from combating boredom to sort of coping, basically. We also know that individuals who start using early, and by early I mean under the age of 15, often use twice as much, or they use twice as often, and they use 3 times as much per week as kids who don't start much earlier. And what we also know from studies is that the earlier you start using, the more often you use, and the greater amounts that you use are going to have a greater effect on executive function later on. We also know that teens seek out potent products because they want greater effects. Teens are always going to want to have that. They're always going to chase that bigger experience, that greater high. And they use methods like dabbing to receive a really large dose of concentrate all at once. And so dabbing is one of the things that we're concerned about too. And I'll talk about that in a second. All right, so let's talk about, it's not just smoking anymore. I don't often, when I first started doing this work about 25 years ago, I talked about one hits and bongs and joints, and then we sort of moved into blunts, and now we're talking about edibles and beverages and concentrates, excuse me, and oil pens. So these are edibles that you can just get in any kind of dispensary. And one of the things that's concerning, so these are chocolate bars, lollipops, these little gummy worms, these little voodoo sours. These are things that little kids are really drawn to. And so a lot of reports that come into poison control and emergency departments tend to be from little kids who got into an adult's edible stash. Another thing that's popped up are these drinks. This is cardamom and orange, blood orange. So this is a cannabis drink that has, it says 2 milligrams THC, 4 milligrams of CBD. These are widely available as well. This is a picture I actually took in a liquor store. All of these products are THC drinks. So it's not just 1 or 2 products. There are many, many different makers of these now. Typically, they're 2 to 4 milligrams a can, but these newer products are containing 25 to 50 milligrams in each can. And this was by a company called Cantrip that I had not heard of. I guess they're pretty new. So one of the concerns about this is that if you were to buy one of these cans, the instructions on it or the directions on it say that you should have 1 ounce, like a little tiny shot of it. The concern would be, though, that if you buy a can of a drink, nobody's going to take just 4 sips of it. They're going to drink the can, and then they're going to end up getting 25 to 50 milligrams, which is a gigantic dose, especially for someone who is not somewhat tolerant or doesn't have experience with it. So those are sort of the edibles and beverages. The extracts and concentrates, when I talk about these high potency concentrates, let's talk just for a second about how those are made. I listed all these extraction methods mostly for myself because I was so interested that there were so many, and we're not really going to focus on all of these. We're going to really talk about the ones using flammable solvents, because these are more of the do-it-yourself kinds of extraction methods that are being done in someone's garage or something like that. But the concentrates are made by extracting THC from the dried plant. And so you could do this actually in a tube sock is what one kid was telling me. So you put the cannabis flower in a tube shaped vessel, and then you pour, say, butane or ethanol, alcohol, isopropyl alcohol or propane through the vessel. And then this pulls out the cannabinoids and the terpenes. These are other, parts of the plant from the material. And then it's heated to evaporate any of the residual stuff. And then you're left with the best part of the plant in this sort of amber colored thing, and it is typically looks like this. And then depending on whether on how you heat it, you either end up with wax, which is sort of like a honeycombish kind of candy, like this honeycomb candy like appearance, and then or you get shatter, which looks like glass, and it's shatter because you break it. It's sort of like a thin peanut brittle or Jolly Rancher candy is kind of what it looks like. So the products are named for their appearance or their consistency. So these runnier ones like this are often called oil or butter. And then as you get into like the powders, it's called crumble. So these are the different kinds of extracts you can end up with. When you go to a dispensary, this is how you would purchase it. So you get a little tiny tin, and I hope you can sort of see these little tiny dots of, these are pretty small. But they have things like lemon cherry jealousy or gorilla sugar cookie or strawberry bomb. But what I want you to notice here is the percent THC. It's 85%, 86%, 86%. So these are the concentrates. These were actually on sale on a website that I just pulled up for fun just to see what they look like. And they're promoted as health products. So there was one that was called Hello Marijuana, Goodbye Anxiety that I saw. And there was another one that was Hello Marijuana, Goodbye Insomnia. So the way they're packaged really appeals to people who are trying to look for symptom relief. So when you get this concentrate, what do you do with it? Well, you would use a vape device. And so this is not combusted. Like if you were to light a joint, that's combusted and it's burned through combustion. Vape pens, and oil pens are actually heated by a battery supply. And then you have a cartridge or a cart that contains vaping liquid, which would be the THC. And it comes into contact with those heated coils, and then a vapor is inhaled. But I want to be clear, that's not water vapor. It's not like a tea kettle vapor. It's actually fine particles that contain a lot of toxic chemicals. And we now know that. The vapor is, it says it's odorless, but you can usually smell it. It usually smells like a fruity kind of smell. But it's very sleek and easily concealed. It's difficult to detect. Kids can do it on a school bus. They can do it walking in the hall between classes. It's really easy to use and not be detected. And I think that's one reason why kids like it so much. So if you look at some of these devices, this literally looks like a pen. This little piece here is the oil cartridge. This is a pen. This is what the oil of the vape pen looks like. Cartridge is usually purchased in a little box like this, and that's what the cartridge looks like. And these are just sort of various devices. The newer devices actually are pretty interesting. Like packs, you can use a cartridge or you can smoke flower in it. You can or vape flower in it. And this is another one that looks like that. So they're very small. They look like little USB devices. They're getting much more sophisticated every minute. Dabbing is a very specific kind of route of administration, and that's when you take a tiny bit of concentration and you put it on a hot surface. You use something called a dab rig, and that vaporizes a very small amount. And this is what a dab rig looks like. It kind of looks like a bong. But the dab that you use, the reason it's called a dab is that it could fit on the head of a nail. It's a tiny amount because it's so highly concentrated. So this is a dab rig. This is a portable dab rig. This, like I said, is not much larger than like a portable USB or thumb drive. This is another device where you could dab or use an oil cartridge. So if you want to do a dab versus just have a hit off an oil cartridge, this is the device. And then this is actually pretty new. These are Aero inhalers that give out metered doses. So this looks like, sort of an albuterol or an asthma inhaler. So this is now on the market as well. So one of the things I want to talk about as a developing concern is something called Delta 8 THC. I'm assuming many of you have probably heard about it. It's marketed as a legal weed. It is found in the plant. It's derived from the hemp plant. And what hemp is a cannabis plant that contains less than 0.3% THC. It's chemically very similar to Delta-9 THC. I have actually seen recently some data showing blood plasma levels and subjective effects, and it really does look like it's about 50% as potent as Delta-9 THC. And you can find it now in vape carts, it's in gummies, it's in chocolate, it's in beverages. It falls into a legal gray zone because hemp derived, as many of you know, is legal. But once you hit above that 0.3% THC, it is illegal, federally illegal cannabis. But there's also a synthetic that can be developed of Delta-8 THC. So some states have it listed as illegal, some do not yet. Federally, it probably still is once it hits that 0.3%. Because it's not really regulated, there can be contaminants in it. Nobody's checking the labeling. So if it says it's 5% Delta-8, it might be 5%, it might be 1%, it might be 30%. And it very much is targeted or marketed towards kids as the legal weed. There have been increasingly higher numbers of reports to poison control and appearances in emergency departments. Some of the data I've seen, 8th graders, about 3% have reported using it, 8% of 10th graders, and about 12% of 12th graders have reported using Delta-8 THC. And compared to 11% in 2023, these numbers are certainly going up. Also, it may not be detected in a urine drug screen, actually. So one thing I would say is if you are talking to kids about their use, we can no longer say things like, do you smoke marijuana or do you use cannabis? We now need to ask them, have you used Delta-9 THC? Have you used Delta-8 THC? Because there are specifically different effects. Another thing that grabbed my attention, and I thought this was really cool, these nano-emulsified beverages. So there is now nanotechnology that basically breaks down THC particles in a way that allows THC to bypass the liver's first full pass metabolism. What that means is that a lot of what people don't like about edible THC is that, any drug that you eat, right, takes much longer for onset of effects versus smoking, which is almost immediate. And so the drinks typically would take about 45 to 60 minutes to feel the effect. These nano-emulsified beverages, the onset of effects is around 6 minutes. So it's much faster. The absorption is faster. There's increased bioavailability. And so what that means is that there are quicker effects and more predictable effects compared to sort of a traditional edible or a traditional drink. And so these specifically the drink or the can will say nano on it. So there's nano here. There's something here called a THC shot. This is a tiny little bottle of it. It's 10 milligrams and it says nano right there. And I just saw it recently in a simple syrup. This drink looks to me suspiciously like, I've already forgotten the name of it. What's the drink that's sort of Cuban? Oh my God, I'm having a memory issue. Okay, anyway, the simple syrup, you can buy it. And this is a nano emulsified THC that you can add to your alcoholic cocktail. I'm curious, I was saying to the panel earlier, I have not seen any THC products showing up in beer or in an alcohol seltzer like High Noon or White Claw. I haven't seen that yet. I'm surprised that's not on the market yet, and that would probably be coming soon, I would imagine. Okay. All right, so let's talk about some of the potential risks and consequences of use. As I said earlier, it's pretty clear that when you're high, you're kind of dumb, but what happens when you're not currently high, but you're smoking a lot? So probably the thing I worry about the most with, a teenager is your risk of developing a cannabis use disorder. About 1 in 3 regular users will develop a cannabis use disorder. If you start smoking before the age of 18, your risk increases about 4 to 7%, or not 4 to 7%, 4 to 7 times. You are 4 to 7 times more likely to develop a cannabis use disorder. About 1/10 of users will develop dependence to THC, and that rises to about 17% if you started using as a teenager. So right away, you can see that use during adolescence really directly translates into greater risk. There's a risk of having withdrawal syndrome, and any of you who work with teenagers or, well, any adults who smoke very heavily and very regularly, especially these higher potency concentrates, you have seen withdrawal symptoms. Pretty much everybody is irritable or moody or agitated or even physically agitated. Definitely you'll hear about decreased sleep and appetite, some restlessness. About 90% will report craving. In the DSM, it says withdrawal lasts about 2 weeks. I would say it lasts way longer than 2 weeks. It might be really kind of peaking around 2 weeks, but I have kids that will report it for a month or two. In terms of memory, reviews of cross-sectional studies have shown that longer lasting use of cannabis, some of the effects, the longer lasting effects of cannabis that we see are in 3 specific domains: in memory, attention and concentration, including response speed, and executive function. And this is the worrisome one, right? This is the working memory, this is verbal fluency, decision-making, judgment, and inhibition. And so the next question would be, if we see these residual cognitive effects, are they permanent? How long are we going to see them? And we have a lot of data in adults, and we know that there is some recovery even after the first few days after they've stopped smoking. And if they stay abstinent for 30 days, we see almost a complete return to baseline by the end of those 30 days. In adolescents, we don't really know. And so when we talk to adolescents, if we're doing harm reduction, you might say, can you only smoke on the weekend? Can you only smoke when you're not in school? But the thing is, if you smoke on Friday and Saturday, are you okay on Monday when you're back in school? Have those effects or those residual effects dissipated by that point? And the answer to that is we don't know. Most of the data that we have are contradictory. Some studies have shown that within 3 days, there's no lasting deficits. Others have found that there are persistent deficits in at least one of those 3 areas. Although overall, we might conclude that most adolescents are going to show at least partial recovery by 30 days. That's a lot less, I think, positive than this adult complete return to baseline by 30 days. So we really just don't know, but it doesn't seem like it's quite as good as it is for adults. Another question I think is important. So let's say you start at 15 instead of 13. Does that make a difference? Is earlier onset of your use worse than a little bit later? So there are some really good comprehensive reviews that have highlighted the impact, and the general consensus is that the earlier the initiation of use, the greater the deficits, especially compared to adult onset or over 18. Starting to use. And we really see those in spatial working memory, complex attention, and again, this executive function, this ability to predict consequences to behavior, to inhibit some of those behaviors, to plan ahead, to use good judgment, processing speed. Really, the big one is this abnormal brain structure and function. When there are changes in brain structure and function, there are going to be concomitant effects later. And again, they're going to be in executive function and memory. So really what we see is a difficulty in learning, that a lot of these adolescents are not performing at the expected level that we'd want to see, and that some of them are working much harder to achieve the same grades and success academically as controls or kids who are not using cannabis. So as I said earlier, we worry about, cannabis changes in the brain. There are multiple studies that have demonstrated a link between use and changes in anatomy and function. And probably any kind of cognitive problems that we might see demonstrated or mediated through those brain changes. And we do see some evidence, a lot of imaging studies show evidence of functional compensation. And we really see that effect strongest for earlier use. And again, the earlier use is going to be before the age of 15 is how that's generally defined. So what specifically do we see in terms of academic performance? A lot of studies suggest impaired function really shows up in psychomotor speed, emotional control, and learning and memory. And these are all consistent. Those are all those are all functions that are consistent with findings of lower grades. So we might see greater school difficulty, lower grades, lower test scores, higher absenteeism, more likely to drop out, or reduced likelihood of graduating. But also, other studies have challenged the specificity of cannabis as causing these problems, because there are other factors like demographics, and these are other liabilities that might underlie both cannabis use and underachievement. So it's really hard to control for some of those other factors in achievement. In adults, we used to call this amotivational syndrome. So these are like, the guy who lives in his parents' basement and plays video games all day, socially withdrawn, hasn't sort of moved on with his adult tasks of like getting a job, getting married, starting a family, and all that kind of stuff. In adolescence, we tend to think more about motivation to undertake educational and other tasks as they transition from childhood to adulthood. So we see sort of apathy, a diminished ability to concentrate or pay attention, following complex rules, learning new material, decreased motivation to perform, especially when the tasks are challenging. And sort of this drive to smoke replaces their drive to engage in goal-directed behavior like schoolwork. And so that starts to compete with those goals. And I included this because this shows why cannabis research is so fun. Pothead rats are up to the tasks, but they just don't feel like it. So this was a study of rats running a maze, and as you got them high, they could still do it if there was a big reward, but most of the time they just didn't feel like it. I don't know why, but that strikes me as funny. So teens lean toward risky decision making anyway. In fact, that's one of the hallmarks of being an adolescent. And so what we do know is that heavy cannabis use can disinhibit and really increase the likelihood of engaging in risk behavior. So things like trying other drugs, mushrooms, sure, why not? I've always wanted to try mushrooms. Engaging in risky sexual behavior that they wouldn't otherwise normally engage in, riding their bikes in traffic. I know a group of kids who thought it was really fun to jump into a dark river at night from a tree while they were high and didn't quite seem to understand that there could be a rock under the water, or it was dark, or they didn't know the river. And of course, driving while high or while smoking or shortly after smoking. 2 in 5 teens report that they drive after smoking. Many teens, interestingly, don't consider cannabis use a distraction to their driving. This is not unlike drunk driving. I still have not met a drunk driver that thought they were too drunk to be driving. What's really interesting, though, is that teen passengers are less concerned about riding with someone who has smoked cannabis than one who has had alcohol. So that, again, that risk perception is different. There's a greater risk for developing a psychiatric disorder, depression. So cannabis use prior to the age of 18 is associated with an odds ratio, which means that they are 1.37 times more likely to develop depression than someone who doesn't use cannabis prior to 18. There's a 1.5 times more risk of suicidal ideation, 3.5 times higher risk for making an actual suicide attempt. Cannabis use is associated with anxiety symptoms, especially for girls. And over time, we know that I often talk to kids about, yes, I understand when you're high or when you're smoking, you don't feel anxious, but that's because you're distracted from it and you're high. But over time, it actually makes anxiety worse. And oftentimes it really develops into social anxiety. Again, girls with cannabis use disorder have higher rates of anxiety and mood disorder. And then another risk is that they're going to try other drugs. They're more likely to use alcohol and nicotine and develop other substance use disorders. And now the big one, psychosis. This has sort of shifted over the last couple of decades. It's really difficult to demonstrate completely that cannabis use directly leads to psychosis, but I think it's becoming pretty clear that it plays a role. It has been consistently linked with psychotic disorder if you start using at a younger age. And the age at the start of use is correlated with the age of onset of psychosis, right? So the association is stronger if you use by 15. It's stronger than if you use at 18. Frequent heavy use during adolescence increases the association, and use of these high potency products is increasing the risk of 6-fold. This was in a review that just came out. So using often and using these high potency concentrates are going to be what increases that risk for developing a psychotic disorder. Another study showed that any use of a cannabinoid ever increases your risk of psychosis 2-fold, and that using cannabis ever accounts for 8 to 14% of cases of psychosis. So really overall, I think the conclusions are that it can initiate the emergence of a predisposition, right? If you have a genetic vulnerability, if you have a family history of a psychotic illness, that's someone who needs to be really careful about cannabis. And so whether psychosis would develop without cannabis, meaning cannabis brings forward the onset, I think it is likely to trigger an earlier onset. I think it can trigger a more severe course of illness and can certainly interfere with the treatment, a successful treatment of the illness. And that's pretty much what's been shown in most of those review studies that I have seen on it. All right, so let's shift over to talk, briefly about screening. Probably the best and easiest measure that's specifically for adolescents is called the craft. And this was developed because the cage questions are not really accurate for adolescents. I like the craft because it's easy to memorize. You can incorporate it into a routine interview. It takes a second. You can also use it for alcohol and drugs, not just for cannabis. It's 6 yes or no questions. Like I said, you can put it in an interview that you're doing. It is validated for adolescents. Have you ever ridden in a car driven by someone who is high? And this is great for adolescents because not all adolescents drive, but they'll get into a car driven by someone who's high. Do they ever use to relax or feel better about themselves or fit in? Do you ever use when you're alone? Do you ever forget things you did? Do family or friends tell you you should cut down? And have you ever gotten into trouble? And these are for adolescents. So one thing about adolescents, if their friends are telling them they have a problem, that's a pretty big deal because kids do not want to confront each other on things like this. So if they say yes to this, that's a pretty big tell. Also using alone, because it's such a social thing for kids, if they are getting high by themselves, that's something else that really should stick out to you. And well, that was weird. So if they answer yes to 2 or more of these, you have a kid that's at risk and probably needs to, you need to ask a few more questions. And so I would move on to sort of a basic assessment. You always want to know how old they were when they first used. When did they last use? What period was their heavy use? Do they only use heavily during the summers or during breaks? Was there a year where they used really heavily? You want to know about the pattern of use, like how many times per week and how much do you use each time? The other thing is that most kids that are using pretty regularly are not using once a day. They're using several times a day, and you need to ask about that as well. I always want to know how they're using. Are they smoking, vaping, dabbing? Are they using edibles? Because that gives you a clue as to how high the potency is. And now this is really new. I used to just ask about marijuana or cannabis. Now I'm asking about strains. I'm asking about what is the percent THC? Is it Delta 9? Is it Delta 8? Are they using heavy CBD strains? Are they using a ratio of 1-to-1 THC to CBD? And most kids will know this now because they're getting stuff from dispensaries where those labels are. And assuming those labels are accurate, which is a giant assumption to make, kids can give you a lot of information. They're actually quite savvy about this. I will have kids tell me that they're using an indica strain and it's, 80% CBD and 40% CBD or THC. But I like to know that just to kind of have a sense of how potent their products are. And then you want to know about consequences of use. Are they showing any signs of dependence? Are they tolerant? Are they using and they can't stop? Have they tried to cut down and they can't stop? I also want to know about family history of problems in treatment, and the use status of peers, because if they're hanging out with other kids who smoke, that is your greatest risk factor for them smoking or them using. See, I still talk about smoking because I'm old. They're using of cannabis. When you're asking about it, if you have a kid who's defensive, most kids I talk to are more than happy to tell me what they use, how much they use, they brag about it. There are some who are court ordered or dragged in by their parents or the security guard at school or whatever. So I call this the 4 Ps. Ask about past use because that's not as threatening because that was in the past. I typically then would ask, these are out of order. I would typically ask about peers use because lots of kids are happy to talk about what their friends are using. Then I might ask about parent use, and then I will ask about their own present use. So you sort of like lead up to this a little bit, and it's not just this giant, are you using? How much are you using? I assume most of you know the DSM-5 criteria for substance use disorder, so I'll be very brief about it, but really there are 3 sections: loss of control. They use larger amounts than they plan to over a longer period of time. They can't stop or cut back even though they're trying to. They spend a lot of time using, getting the stuff, recovering from use. They give up activities because they'd rather use, and they report a lot of craving. And then there's the physiologic group, which would be tolerance and withdrawal. And then consequences of use. Are they using it in dangerous settings? Have they had fights with friends or family over their use? Are they not making it to school or making it to their job or doing homework, not doing homework because they're using? And do they know they have these problems, but they continue using anyway? So all you need is 2 of these in the past year to earn a diagnosis of a mild substance use disorder. So the severity is ranked by the number of symptoms. So you have a mild, a moderate, or a severe disorder. I also would want to caution you, tolerance and withdrawal alone don't necessarily imply a disorder. So if they only say, I've noticed some tolerance, I can smoke a little bit more and not get high. And when I don't smoke, I can't sleep, I don't have any appetite, and I feel kind of moody. it used to be that those two would get you the diagnosis. Now we realize that that's not necessarily meaning that you have a disorder. Okay. So one thing I would caution you about is that a lot of teens might not meet those criteria, right? Because a lot of them are not driving, they don't have a lot of obligations. So really what you might be looking for is they have a hard time sleeping, their behaviors become disruptive, they might be depressed, they're avoiding school, there's been a decline in academic performance, they might have an increase in anxiety, rapid changes in mood, or what I would consider hostile outbursts, and parents will sort of report this, and that's typically a clue that there's a pretty strong withdrawal, acute withdrawal syndrome. If they have all new friends, because their old friends don't get high, and so those friends won't hang out with them anymore, so now they've had to make new friends who use drugs. If they won't introduce these new friends to their parents, that's often a sign. And then sneaking out, lying, locking doors. If you had a kid that used to come home from school and throw his backpack on the dining room table, and now you never see that backpack, that would be something that would raise my concerns as a parent. Money going missing, stuff like that. All right, so let's talk about intervention. Unfortunately, we have no FDA-approved pharmacotherapy for cannabis use disorder. It's not for lack of trying. We've been trying for 2 decades, and we've tried every SSRI, every SNRI, every atypical antipsychotics. We've tried a lot of different things. There have been 2 clinical trials in teens looking at N-acetylcysteine, or NAC, which is found over the counter. It's everywhere now. It's in CVS. And it looks like 1,200 milligrams twice a day for at least 4 weeks in these teens showed reduced craving and actually reduced some use over those 4 weeks. So I certainly would recommend that to any teen that you've seen that is trying to stop or cut down or says that craving is why they keep using. Behavioral and psychosocial approaches would include cognitive behavioral therapy, motivational interviewing or enhancement, and then contingency management. The best would have all 3 of those. Teens do better with some treatment than without any treatment overall. These are the evidence-based treatment approaches. There's a lot of them, so CBT, group or individual. CBT, if you can combine it with a motivational approach, and CM, that would actually be what this community reinforcement approach is. It's called CRA or ACRA. ACRA just means it's the adolescent version. Multidimensional family therapy, family behavioral therapy, functional therapy. So all kinds of family therapy. These are our evidence-based treatments. What I want you to think about is all of them sort of as a group because they work, but very modestly so. We do often see initial decreases in use and dependent severity. They don't often maintain. None of them are clearly superior to any other one. The problem is about 2/3 of teens are going to continue to have significant substance-related problems after treatment. Many never actually become abstinent, and many relapse after an initial success in treatment. So what the review studies have really said is overall they're effective, but it's pretty modest. And the largest clinical trial to date, and it's pretty outdated now, it's about 20 years old, looked at 5 outpatient treatments for cannabis, shouldn't say abuse, but cannabis misuse with adolescents. So they looked at a motivational approach with 5 sessions of CBT, motivational with 12 sessions of CBT, motivational with 12 sessions, and a family support. This community reinforcement approach, which I said I loved, that combines motivational CBT and contingency management, and then a multidimensional family therapy. And all I need you to take from this is that there's an initial decrease. All of them are the same. None of these emerged as the clearly, so 5 sessions of CBT and you double it to 12, didn't really do much. You add on something else, it didn't really do that much. Add on the family therapy, it didn't really do that much. They are not distinguishable from one another. All right, so let's just talk about some developmental issues in treatment, how it's different than adults. Teens rarely come in and say, Dr. Lundahl, I really need help with my pot smoking. It's out of control. Usually they're brought in by a parent, a guardian, a probation officer, or school, or it's court ordered. Most of them do not see cannabis as a problem because it's medicine, it's legal. What's the problem? Motivation and efforts to quit are really low. And so mostly because of that, I never really use abstinence as an initial goal with a teenager, because as soon as you say, we need you to stop smoking pot, they just tune out and aren't going to do anything. If you say harm reduction and you say, okay, if you smoke 4 times a day, how about you give up that one in the morning when you're driving? Or how about you give up the one in the middle of the day when you're going back to school? How about you only smoke at night when you're home safe for the night and you've done your homework? So harm reduction is really where I would go. Very few teens are going to achieve abstinence after one treatment episode. They are going to bounce in and out of treatment. And I always say, consider your outpatient teen to be a continuing user, no matter what kind of treatment they've been having. So that was a very negative note to end on. But anyway, some final thoughts. Rates of use have come down a little bit, but they're still really, really high among adolescents. We know that this period of brain development during adolescence means they're extraordinarily vulnerable to some of those effects. There's a really high risk of developing a cannabis use disorder and other substance use disorders. We know that the acute cognitive effects are really clear. Not entirely sure about the residual effects, but it doesn't look great. There are clear mental health effects, psychosis, depression, anxiety, much higher risk. And overall, if you're high all the time, you're dealing with a sort of dialed down brain a lot of the time, and that can translate into lower grades, less likely to graduate high school, less likely to go to college, and reports of lower career success and less happiness with family and peer relationships. So I especially tell parents, and if you can delay initiation, that's huge. If you can get them to 15 or 18 or ideally 26, that would be great. If they're using, at least discourage regular use, and please try to discourage these high potency uses. When you ask them about their products, you now have to ask them, is it Delta 9, Delta 8? Is it CBD? Are you vaping? Are you dabbing? Are you smoking? The legal definition of adult doesn't correspond to brain development, right? We know that 18, you still have at least 7 more years of brain development that you're going through. And overall, it's really hard to see that marijuana legalization is going to improve public health in any way, especially for adolescents. And I will get off my soapbox, and that's my story, and I'm sticking to it. Whew. I saw the hook coming out, so I tried to finish fast. Sorry about that.
Thank you so much, Dr. Lundahl, for your presentation. As a reminder, please enter any of your questions that you have into the Q&A box at the bottom of your screen, and we will try and get to as many questions as we can. So with that, we're going to start with our first one. How do other Delta variants, Delta 8 and Delta 10, compound or affect THC effects?
Yeah, that's a really good question. I don't know if we have any data on that. I mean, the thing is that Delta 8 and Delta 10 are found in the plant, but they're really small quantities. So I'm not really sure if we've isolated the effects from Delta 9 because they are the same effects, if that makes sense. Right. So when you're smoking the plant material, it's really hard to know to isolate those because they're the same effects. But the data that I have seen where they compared 8 and 9, 8 literally was half in plasma level and subjective effects, like I feel high, I like this, stuff like that. I don't know about the compounding, though. That's a good question.
Thank you so much. I agree with this person who put this in the chat. I was kind of amazed when you showed the THC infused drinks at the liquor store.
I know.
So their question was, how is it legal for a liquor store to sell THC infused drinks?
Because technically I think they can be it's legal to sell they're legal beverages. You're able to sell them. I can't remember which state this was in. And I know in Canada, they're also in beverage stores as well. The dispensaries will definitely have them, but I think this was North Carolina. I'm not really remembering which store this was. I was shocked as well. But
yeah, it was definitely very colorful.
It was very splashy, and it was,
yes.
you couldn't miss it. You could not miss it. It's kind of crazy. Yeah.
For sure. Our next one is, how much, if anything, do we know about the combined effects of alcohol and cannabis together?
Actually, I know of a study that looked at driving. So they had this really cool driving simulator, and they administered, I think, placebo, THC alone, alcohol alone, and then THC and alcohol. And what was really interesting is that alcohol is by far the most impairing, and THC and alcohol bumped it up a little bit, which was sort of scary because THC adds, so alcohol really has this disinhibition and unsteadiness. THC adds lower response time or a higher response time. So it takes longer to respond to something. The other thing that THC does to the brain is that it lowers your peripheral vision. So you don't see things coming at you from the side. So if you add those together, you don't see things coming from the side. When you do, it takes much longer to respond to it. So there's definitely an enhanced impairment with both of them.
Thank you for answering that.
Mhm.
Our next participant asks a little bit more about your role at Wayne State, and they asked, do you teach any classes at Wayne State to help educate the college students on the dangers of THC?
You know, I wish they would ask me to, but no, I don't think we have. I know in psychology they probably have like a drugs of abuse kind of class, but not specifically about that. I do teach one class in the medical school where we talk about the effects of some of these drugs on the brain and behavior. We don't really have a cannabis specific curriculum, which I think we should, because I mean, it's just exploded in use. And so I think that's a really good idea. But I'd unfortunately no, we don't.
Thank you. Someone should definitely put that in the suggestion box.
I agree. I agree.
Our next viewer asked about data, and just that some of the data that you presented about was a little over 10 years old.
Mhm.
There was also some up-to-date and more current data, but they wanted to know where's the best place to get the most up-to-date data if they wanted to do their own research.
It's a good question. I mean, if you go to the NIDA website, so the National Institute on Drug Abuse, and that's under the NIH umbrella, they will often have like press releases of newer data that come out. And there are also very specific groups that study this. So if you're thinking about like the cognitive effects, there's a group at Harvard, at Mass General Hospital. So I refer to a lot of their data. So yeah, that's probably what I would do. But I think the NIDA website would be a good place to start.
All right, great. Thank you so much.
Sure.
Our next question is, can you share anything about where 18 to 22-year-olds fall between statistics for adolescents versus adults?
Or, I'm sorry, statistics?
Yes, yeah. If there's like where you can differentiate them in the statistics for adolescents versus adults for
For
18 to
you,
22 year olds.
for use, you mean? Or
Yeah, I think so.
okay.
They weren't specific in their question, so we'll go with
Okay.
use.
Okay, yeah. Well, we know that 18 and 25-year-olds that's the age group where use is heaviest. That's the most frequent and the heaviest use. Although very interestingly, the group that's taking over for the highest number of newest initiates, meaning that they've never used before, is people over 50, which is really interesting, right? So that's the next group that's going to be after the 18 to 25-year-olds. But yeah, their use is definitely higher than the teenagers. The 18 to 25-year-olds, not the 50-year-olds.
Yeah. No, thank you so much. Well, I think that was about time for our last question. So I'm just going to go over some closing remarks really quick. But again, thank you so much, Dr. Lundahl, for taking your time and speaking with us today. I hope our viewers were able to find this informative and interesting as much as I did, because it was amazing. And we are so appreciative that you came back for us this year for our Cannabis in Practice webinar series.
Thank you for having me.
Thank you. So we would greatly appreciate your feedback so that we can continue to improve our future webinar offerings. Please use the link in the chat or the QR code on the slide to complete our feedback survey. As a reminder, this live webinar has been approved for 1 social continuing education clock hour, 1 specific McVAP credit hour, 1 Mishwa credit hour, 1 CHES credit hour, and 1 credit hour of CME. If you are requesting any of these continuing education credits, you must fill out our evaluation form with your name and email address. For the next presentation in our series, Dr. Jason Kilmer will be presenting Addressing Cannabis Use Through Screening, Prevention, and Intervention Efforts tomorrow at noon Eastern Time. If you have not yet registered for our other webinars in this series, you can do so by using the link in the chat or visiting us at washtenaw.org/marijuana. We hope to see you at the next webinar. And again, thank you so much for everybody's participation today.